Welcome to the second DIIU webinar for 2021, Improving Access to Primary Care for People with Severe Mental Illness. This event is presented by the Disability Innovation Institute at the University of New South Wales, Australia, and the Division of Equity, Diversity and Inclusion, UNSW. I'm Jackie Leach-Scully, I'm Director of the DIIU and also Professor of Bioethics at UNSW. And I'd like to start with the acknowledgement of country that's customary in Australia. I'd like to acknowledge the Cammeraygal people who are the traditional custodians of the land from which I'm speaking to you now, and the Gadigal and Bedigal people of the Eora Nation, the traditional custodians of the land on which the UNSW Kensington campus sits. I pay my respects to the elders, past and present, who hold the memories, traditions, culture and hopes of Indigenous Australia. I'd also like to extend that acknowledgement to all Indigenous people with us today. As we share our own knowledge, teaching, learning and research practices across our universities, we also pay respect to the knowledge embedded within the Aboriginal custodianship of country. If audience members have any questions during the event, or if anyone is having any difficulty and can't use the Q&A function, please email us at diiu@unsw.edu.au, or if necessary, phone 02 9065 8340. AI Media is providing the live captioning today. If you're unable to see it, please email us again at diiu@unsw.edu.au. And please note that we have two Auslan interpreters from Sweeney Interpreters who will be on screen alongside the speakers. The audience Q&A will be conducted via the Zoom Q&A function at the bottom of your screen if you're on a web browser or mobile device. Please post your questions here and they'll be passed on to the presenter at the end of the talk. And please feel free to join the conversation online. You should be able to see our Twitter handles here on the slide. Quick word about DIIU itself. The DIIU at UNSW is a world first initiative focusing on disability research, education and knowledge exchange. We pride ourselves on undertaking work that's radically inclusive and crosses disciplinary boundaries. Our approach is to see disability not as a problem to be solved, but as an integral part of the human condition to be encountered and engaged with rather than feared. And it's in this light that I'm delighted to be here to open this webinar. I'll now hand over to Professor Eva Stranadova, DIIU's academic lead research, to introduce today's speakers.
It is my great honor and privilege to introduce to you Dr. Catherine Spooner and Dr. Peri O'Shea. Dr. Spooner is a senior research fellow at the University Centre for Primary Health Care and Equity in Sydney. She's leading a program of inclusive research at the centre that aims to identify and trial interventions that can improve the physical health of people with severe mental illness. Dr. Peri O'Shea is a lived experience researcher who specializes in qualitative, participative research, which is aimed at improving the health and lives of people with mental health challenges. Her research work draws on academic skills and her own life experiences as a consumer and carer. So it is my great pleasure to pass it over to you, Catherine and Peri.
Sorry, thank you, Eva, and to Jackie. And welcome to everybody who's on the webinar. I can't see you, so I trust you're there. I'd like to acknowledge our co-investigators. So it's Peri and I presenting, but we are representing a team including Ben Harris-Rohard, Jane Taggart, Patrick Bolton and Mark Harris from the Centre for Primary Health Care and Equity, and Karen Fisher from the Social Policy Research Centre. Okay, so in this presentation today, I'll be presenting the background where I explain what we mean by severe mental illness, and what the problem is that we're trying to address through our research. I'll present some theoretical frameworks and guidelines that have helped us in our research and our analysis and the specific study aim. And then Peri will provide the methods and results from the research. And then it's back to me to talk about what we learned and the implications and what we've done since. So what do we mean by severe mental illness? Well, there's many diagnoses or many definitions, but what we've used is one by Whiteford. It's also used by the World Health Organization and others, where there's 3 criteria. So it's about it being severe in degree, persistent in duration, so it's not a short-term thing, and it causes a substantially diminished level of functioning. So most severe mental illnesses include psychosis, which is primarily schizophrenia or bipolar affective disorder. Also severe depression and severe anxiety disorders can be included as severe mental illnesses. And for those who are not familiar, psychosis is where a person loses the capacity to tell what's real from what isn't. And we're talking about 3% of the population. So while the majority of the population have experienced some form of mental health problem in their lives at some point, or perhaps multiple points, severe mental illness is really quite a specific small group of the population. However, the problem is that people with severe mental illnesses die about 20 years earlier than the general population, and the majority of these deaths are due to preventable diseases. It's not primarily suicide or specifically related to the mental illness, but they're preventable diseases. And people with severe mental illness have been found to experience issues accessing primary health care and preventive care. So the picture there is because my background is public health and I really love statistics. So we'll do this really quickly, just because I can't help myself. So this gives a real picture, though, of what we're talking about. To say that the life expectancy gap is about 20 years, it also seems to be growing. So relative to the general population, people with severe mental illness are 3 to 4 times more likely to die prematurely. In fact, even though they only represent 3% of the population, they account for 1/3 of all avoidable deaths. When we talk about preventable conditions, we're talking about conditions such as cardiovascular disease, respiratory disease, and infectious diseases. So people with severe mental illness are 6 times more likely to die from cardiovascular disease than the rest of the population. So what's feeding those preventable diseases is modifiable risk factors. So people with severe mental illness are 2 to 3 times more likely to have diabetes, twice as likely to live with obesity, 2 to 3 times more likely to smoke, 2 to 3 times more likely to have high blood pressure, and 5 times more likely to have high cholesterol. So what's causing this? Well, the World Health Organization has been, amongst others, has been looking at this because it's an international problem. And as you can see in the cloud over there, service delivery or health service delivery is just one element of the problem. And this is, we're from the Centre for Primary Healthcare and Equity, so that's our focus. And so therefore, given that there's a large range of multi-level problems contributing to this morbidity issue and mortality issue, part of the solution is with the health system, and GPs are a major part of the health system. So they're really our focus here as major providers of preventive health care. So why are people with severe mental illness not getting full access to primary health care and preventive care? There's a lot of reasons. These are just a few of the major ones found in the literature. One is the stigma towards people with severe mental illness, resulting in health staff not treating them with respect and with compassion. poor communication, so not really listening or being unable to really understand the issues for people with severe mental illness, and diagnostic overshadowing. So that's where everything is seen through the lens of the mental illness. So a person might go to the GP and the GP might say, well, you know, you're just imagining that, it's part of your psychosis, or that's not really the important thing, how's your mental health going? Also, consumers have difficulties. People with severe mental illness often have cognitive difficulties that might impact upon their ability to access primary health care, often low health literacy, which is about knowing how to address their own health and get the services they need. And the mental health condition themselves can be a barrier to accessing the general practice. So there can be anxiety about leaving the house. So our study aim was to identify what helps people with severe mental illness to access a GP and to establish and maintain a positive relationship with their GP in order to prevent, detect and manage long-term physical health conditions. So there is quite a bit of research on the barriers, but you know, what can we do about those barriers, and particularly in Sydney in our health system? And this small study that was funded by the Disability Institute has really sparked a whole program of research at the Centre of Primary Healthcare and Equity. You know, we're really wanting to address this health equity gap, and I'll talk about that more at the end. So our work has been guided by theoretical frameworks of access and the RACGP guidelines for preventive care in general practice. And I'll explain that now because when you're outside the primary healthcare bubble, you won't necessarily understand what we're talking about with these terms. So GPs do have guidelines for preventive activities in general practice, and this is for everybody. They have a role in screening, monitoring, prevention and management of chronic disease, vascular disease, cancer and psychosocial problems. So all of that screening of smoking, your blood pressure, your blood tests and in immunisation. And there's also an approach outlined for preventive care by GPs. It's called the 5 A's. Ask, assess, advise, assist and arrange. So it starts with ask about risk factors, you know, such as smoking, such as diet, exercise, and assess the level of risk factor. So say for smoking, you know, how ready to change might the person be? They might not be ready to address it. Giving advice, it can be written information, brief advice, helping the patient to negotiate goals and targets, assisting the patient in practice to develop perhaps a risk factor management plan, perhaps some education, perhaps some support for self-monitoring. It could be, if it's about being overweight, about monitoring diet and exercise. And most importantly, because we know we only have a microsecond with GPs under current bulk billing arrangements, there's not a lot that can be done in the practice, but the GP can arrange for referral to lifestyle programs and other allied health, and also arrange for follow-up for the patient to come back to talk about how the progress has been. So being proactive in preventive care. So this across the screen is just a couple of examples of a couple of the risk factors, and which I have sort of mentioned. I'll look at overweight. So with the assessing, it's measuring waist circumference and weight and height to calculate body mass index, providing advice on realistic goals, because for overweight, everybody has unrealistic expectations or goals around losing weight. Assisting with a tailored weight management plan with specific goals, and also arranging some referrals for assistance, and most importantly, the follow-up visit, coming back and reassessing. So GPs are expected to do this with all patients. Also, as I mentioned, we're concerned about access to care, access to healthcare. And access isn't a simple thing of, location. If you look at the blue section in the middle, you'll see getting consequences of healthcare. So good health starts with identifying the need for healthcare, and then seeking healthcare, reaching healthcare, engaging well with the healthcare when they're, with the GP, to, as I said, get the positive benefits. But there are a lot of factors along the way that can interfere with the positive benefits of healthcare. So on the provider side, which is on the top, how approachable is the GP? How acceptable is the service they provide? How available is the accommodation and appropriate is the accommodation? How affordable is it? And how appropriate is the care that's given? And communication is a very important factor of appropriateness. Looking down the bottom at the patient side of the equation, the patient needs to have the ability to perceive the need for health care, needs to have skills in seeking health care, needs to be able to reach the health care, and that can be just about transport or mobility, needs to be able to pay for health care, particularly where there's out-of-pocket expenses. And it needs to be able to, the patient needs to be able to engage with healthcare. So really to communicate and understand what the GP is saying. Now I'll hand over to Peri, who is our lived experience researcher.
Hi everybody, hopefully you can see me because I can still see Catherine. Okay, excellent. Hi, I'm Peri. And as Catherine said, I'm a lived experience researcher. I should say up front that I haven't got a lived experience of severe mental illness in the definition that we gave, because luckily I've somehow or other managed to function, at least partly. But I am a carer of somebody very close to me that has a severe mental illness under that definition. Okay, Catherine, if you'd like to move on to I'm going to talk about the research method and the findings. So first of all, I just like to talk a little bit about the research design, because I think this really underpins what we did. And the design was very much designed around the guidelines of the Institute. So we had a multidisciplinary team. So on our team, we had people with medical backgrounds, public health backgrounds, social policy research centre, so social policy backgrounds, a social worker, people that work directly within mental health within New South Wales Health Service, and of course myself, who has a lived experience. And we worked under the principles of equal partnership, that everybody works together. The idea was that we gather some information, we present it to a larger group, and we all work together to look at how we can actually improve the healthcare of people with a severe mental illness. Next slide, Catherine. Okay, so here I describe the methods. The study population was adults with severe mental illness, with those three things. Remember, severe mental illness had to do with the severity of the illness, the functioning, and right now I've forgotten the third thing. Oh my goodness, sorry. It'll come to me in 1 second. And some people are probably yelling it out at the screen. And we actually interviewed people, consumers and carers in southeastern Sydney, which is where UNSW sits, and also quite a few of the people on the research team that work in New South Wales Health work in that LHD. So we use the term consumers here. Like we talk about people with severe mental illness, I might interchange that with consumers, because that's sort of the terminology that I'm used to using. And of course, that doesn't mean that it's a contentious term, but what we're talking about is people that have a severe mental illness in this context. So, and we recruited people via the local mental health service, the LHD, but particularly the community mental health service in Southeast Sydney, in Eastern Sydney actually, and also we partnered up with a community organisation that's NDIS funded. We talked to people that have experience of mental illness, and also sometimes they're carers, they're NDIS carers, or support workers in people's homes, at services. We talked to people within the public mental health service as well, and sometimes other places where they felt comfortable, like a cafe. We spoke to a couple of people in a park. The data collection, what we did is we did 10 interviews with consumers, and then did a focus group with another 10 consumers. And we also spoke to 5 carers over the phone. And after we got all that data together, we then ran a knowledge exchange where we invited consumers, service providers, and lots of other stakeholders, and also their support, consumers to support people, to really flash out, what all this data meant and what we can do from here. I was trying to push the button to get the next slide, Catherine. We need the next slide. So what did we find out? Well, going back to the Royal Australian College of GPs 5As, and just looking at the data from that framework, we found out that that some GPs, and also I should say up front, remember we only spoke to consumers and carers, so this is all from that perspective. And then when we did the knowledge exchange, we were able to bring in the other perspectives as well. So overall, a couple of GPs were asking about physical health, and that had been improving. But we also did see some evidence of what Catherine talked about as overshadowing, where sometimes people had to get quite severely physically unwell before that was noticed. In terms of assessment, definitely there was some evidence of GPs doing assessments of health risk behaviours for preventative care. Some people talked about the GP taking their blood pressure, weighing them and so on. But there was much more evidence of this assessment happening within a mental health service that we access, that actually concentrates on the physical illness as well as the mental health of the people that go to that mental health service. So across the board, GPs, some GPs did it, a lot didn't do the preventative care assessments. But we did see some good examples of this happening, and we also saw a much more regulated example through the mental health service. Definitely consumers told us that some GPs gave them advice regarding risk behaviours, particularly diet, exercise and smoking. It was unclear whether GPs actually did any motivational interviewing, which is one of the 5As, or an example of the advice and agree that the Royal College talks about. But that might be because they didn't really use that type of terminology, or they might not have even really been clear as when the doctor might have been interviewing or encouraging or supporting them in that way. But definitely there was some examples of doctors that help with goal setting. Some consumers actually had some listed out goals that they'd worked out with their doctors, or they were able to tell us about goals, particularly again around managing diabetes, and diet and exercise, and also the cessation of smoking. So also there was some examples of doctors assisting people to improve their physical health. One great example that I remember when we went into a consumer's home was a big sign was handwritten behind the door that said no smoking after 5 p.m. And the consumer told us that he'd had a chat to his doctor, probably motivational interviewing, about when he was most likely to smoke and where he was most likely to smoke. And it was after 5 p.m. and it was outside of his flat. So the sign was there to remind him if he was going to walk out of his flat after 5 p.m. not to smoke. And that was something that the consumer had agreed was a good idea and was actually doing that. So there were some good examples there. And not surprisingly, as Catherine mentioned, you're not in the GPs for very long, and GPs are often like a vehicle to the next stage. So there was quite a lot of evidence of referrals to specialist services, particularly diabetic clinics and other services around respiratory issues and stuff. Catherine, thank you. And so how do we go in terms of the access model? Sorry, just keep up my notes where we're up to. So in terms of the GPs, the top row there, which is the providers, you know, looking at it from the perspective of the providers, as I've already mentioned, we actually collected the data from the perspective of the consumers. And so there might be things that we didn't get told because they weren't obviously happening as far as the consumer was concerned, but there was a lot that they told us that were examples of how well this was happening out in the primary healthcare arena. So the first one, approachability, we found that while there was some GPs, we found that while for most of the time people could actually find a GP or had been going to the same GP since they were quite young, or went to the GP that was in the local area, or went to you know, a medical centre within their local area. And there wasn't really a lot of GPs, from evidence that we could see, GPs sort of coming out to look for or setting up their services in such a way that would get people that had a severe mental illness to sort of say, oh, that's the GP I would like to go to. There was, though, an example with the mental health service that we were working within, where the mental health service made links to a local GP and provided some capacity building too with that local GP, so that they understood how to work with people with mental illness a little bit better. And people with severe mental illness were more inclined to go and visit that medical centre for that reason. So that was a good example of some outreach work going, but the outreach was from the mental health service to the GP. But it does show that it could work. So in terms of acceptability, the things that really stood out for us was the manner of the GP, whether they were judgmental, whether they were abrupt or open, and also the gender of the GP, is whether that was acceptable, whether somebody would access them with a severe mental illness, would access them in the first place and would return. And then we look at the availability and the accommodation. These is really important in terms of access. And there's like a journey, right from when you make the appointment to getting there, to sitting in reception, to waiting, then to going in to see the GP. So what we did find is that GPs that had flexible ways of making appointments didn't leave people on hold. Some people with severe mental illness actually didn't mind the flexibility of being able to make an online appointment in the middle of the night. Others didn't have that capacity or that technology. Some people needed their support worker to help them with making the phone call, whether they just sat beside them or made the phone call for them. So that there was lots of there's lots of things around being able to access just by making the appointment. Getting there was also something that often required support, and it might have required some flexibility if somebody was late because they missed a bus or things went a bit pear-shaped. I'll talk a bit more about some of these things when we talk about the consumer's capacity as well. The reception was really important in terms of how available and accommodating a primary health care was, and whether or not a person could access it in the first place and also would come back. So if there was felt there was any judgment or misunderstanding or discrimination within the reception by the receptionist or from other people in the waiting room, that might actually stop somebody from staying to actually see the doctor or to come back. So GPs that people with severe mental illness really like to go and see were ones that had a lot of flexibility around the reception, that the receptionist themselves was very welcoming and accommodating. If there was waiting, that there was somewhere they could wait where they could feel safe. They could maybe go outside and get a call to come back. And some people with severe mental illness told us that they liked it when their doctor actually would make sure that they didn't even come into the doctor's surgery until the time it was that they were there. It was their time, and that they might shift things around if somebody else was in front of them and the doctor was running a bit late. So a lot of flexibility there in terms of availability and accommodating people and their needs. Affordability, we found the consumers went to GPs that bulk billed, but there is some issues there in terms of the cost of preventive health care programs and specialist appointments and so on. And again, the appropriateness of care came down again sometimes to the manner of the GP, how well they communicated, whether they were open or abrupt, whether they actually asked questions or just made assumptions. And sometimes those assumptions, as I spoke about before, could result in overshadowing. There's quite a few examples that we got of that overshadowing. Okay, thank you. And one of those was that there was one consumer that we spoke to that became really unwell really physically unwell before anybody noticed that she actually was unwell. What we also spoke to quite a few people that were quite overweight, had some quite a few issues with respiratory and diabetes and so on. And even though these things were now being addressed, it had taken a lot of time for those things to be noticed and taken up, because the doctor was concentrating on their mental rather than physical health. So just very quickly, looking at the bottom of this table here, in terms of the consumer's capacities and abilities, really the consumers on the most were able to perceive when they had a physical health care, and often the frustration was that they couldn't really get that message across, but sometimes their mental illness did prevent them from being able to see past their mental illness to the physical. But most of the time it was that they could see that they needed physical health care, but other things might have stopped them from actually seeking that physical health care. Again, the main ones probably their mental illness itself. So for example, if somebody had severe anxiety, it can be very difficult to get on a bus or a train, or even get into somebody else's car or get past the letterbox to get to an appointment. And also this often people experience discrimination or experience quite a strong fear of being likely to be discriminated or feel like they're being judged in some way. And looking at the ability to reach, again, they often needed support to get there. So that might be a support person, and often it might have been some travel training with an NDIS support person, and then NDIS funding to subsidise bus fares and train fares. Sometimes, again, as I talked about a minute ago, their mental illness can make that ability to reach difficult. And again, discrimination on the way there can also be something that might stop somebody from going, or at least whether it's discrimination or not, but definitely a perception that you're being judged or discriminated against, often based on real life experience that haven't happened in the past. Most consumers told us they did have the ability to pay because it was bulk billed, but they also told us that if it wasn't bulk billed, they would just have to go to a different GP. And they did talk about some stresses around being referred to a specialist service and needing to make sure that was also going to be bulk billed. and if it wasn't, they also again wouldn't be able to engage with that service. The public mental health service that we did our study in also provided free physical and mental health services, but again, that's, you know, these things are often very limited in the amount of people that can access them. And people's mental illness and they've been disordered can also make it difficult for people to engage with a GP, and support again helps here. Catherine, I'll get you to show me the next slide, and I'll go a bit faster. Okay, so just really quickly, this is the same slide, but there's just some themes that cut across all of these categories. And for the providers, it's good communication, some knowledge and understanding about mental illness, and being really flexible. And for consumers and carers, for capacity, it's getting the support to be able to perceive, seek, reach, pay, and engage. And it's also making sure that they feel safe and not discriminated against within services. And that also can help address some of those mental illness issues as well. So the key findings, what we found worked was definitely that intensive support. So sometimes it might even be like intensive support might be just until the consumer's ready to do it alone. So it might be, like I said, that travel training or helping them ring up the doctor or going with them the first couple of times, and then they're able to go by themselves. We had lots of stories like that from consumers. Also the GPs that focus on people's physical health when that's why the consumer is seeing them. You know, we had one man that went to the doctor about a sore foot, and the doctor spent the first 10 minutes talking about his anxiety, and he's like, I've got a sore foot. GPs that take the time, listen and take action about the consumer's concerns. And lots of people said this, GPs that get it, that just get what it's like to be a person that has a severe mental illness, what we're experiencing here. Medical rooms that make and GP rooms that accommodate people's specific needs. Medical centres with more than one doctor, so that if something did go a bit pear-shaped or you needed an appointment one day, you could go to the same place. And also if there was other specialist services online, people were much more likely to go straight to the specialist service in the same place in the next place. Catherine, would you like to go to the next slide? So what do we need to improve? I sort of say this first one much more of what works in tongue-in-cheek, but not really, because as I've already said, and what we recognise even before we did the study, is that there's some really pockets of great practice out there, some really good services, but they're really for the lucky few. So what we do need is much, much, much more of what works. We need better follow-up. So now at the moment, a lot of people told us that the doctor had given them a referral for a blood test or a specialist, or told, sat down and told them how they can improve their diet. But then from then the onus was on the consumer to go and do that. And there wasn't necessarily good follow-up to make that happen. Like, we know ourselves that when we're busy and there's lots of stressful things going on, we might not ever get round to that. But if you've got a severe mental illness, it's much harder to do that. And yes, we should probably spell onuses right. Thanks, Catherine. Much more focus on preventative health, and much sooner, as I said. Quite a few people we spoke to are now in the frame for, yes, you have some physical health problems and there is some stuff happening now for them. But it took a long time to get there, which means that they became very unwell before that happened. Resources to assist people on limited income and like social capital, community development projects to improve people's health. Yes, thank you. And increase free access to specialised services, as I've already talked about. Dental is a particular issue for people that have mental illness, severe mental illness, and access to appropriate information about preventative health for doctors, consumers and carers, so they can move away from the stereotypes, not be fearful of people who have mental illness, be less judgmental, know more about what's actually really happening. And that's it. Well, not it for me, but that's that slide. Sorry, Catherine. So then we had the knowledge exchange workshop, and after we discussed all this data, these are the things that we actually identified a need for. Some real navigation and support. So, you know, that support that I talked about is absolutely necessary in terms of helping consumers to access and follow through on primary health care. But it needs to be more across the board and much more targeted. A lot of GP capacity building and a mechanism to enable shared care with the GP as a central point of the care. And I think that is it for my slides.
Oh,
That's you, Catherine.
Oh, sorry, I'm trying to find my camera. Can I start my camera? Ah, thank you. Thank you. Okay, so I will be quick because we're getting short of time, but that was great. It's really hard for Peri to really, you know, provide a quick overview of it's so complex, all the issues that came up. And I guess that's part of what we discovered, that we need a multimodal intervention because we can't have, there's no quick fix. There's a lot going on. We need a partnership approach, and clearly, particularly between mental health services and GPs, you know, sort of working together in shared care, and a very consumer inclusive approach. I mean, we've discovered just in this project how much having consumers involved helps us to understand the problem and do a better job of researching it. So for policymakers, you know, acknowledging it's a complex field, too often we have short demonstration projects. You know, we need a really long-term coordinated approach to addressing this huge health equity issue. For primary health networks, have a role in training and supporting GPs to be able to provide the best care for all groups in their community. And GPs also, you know, I know there's a lot doing a really good job, and we heard people talk about it, but it is about trying to accommodate the needs of all of their consumers to make sure everybody feels comfortable. And Peri talked about that to some degree. And I just want to mention that thanks to this Disability Innovation Institute small grant, you know, seeding grant, since then it's really helped us put a foot in the field to be working at intervention trials. So we have an electronic shared care trial happening now. We got funding for in Sydney LHD and Southeast Sydney LHD. The Southeast Sydney one is with the Clozapine Clinic, and the Sydney LHD one is with 4 adult mental health teams, and these are done in partnership with the LHDs. So they're taking up, you know, using electronic shared care programs to help better communication between GPs and the mental health services. So it's really exciting that something's happening, because the field is desperate for things to improve with the mental health services. We've also been commissioned with Swinburne and Newcastle universities to develop resources to help primary health care to be more responsive to the needs of people with lived experience of mental health issues. So not just severe mental illness, but the broader spectrum. We also got funding for a Scientia PhD student who's using co-design to develop a tool to assist with GP communication. So we're doing a lot, has sprung out of this small study, which helped us to learn our, you know, get some networks happening and have a better understanding of how to work in this field. So really grateful to the Disability Innovation Institute for that. Oh, didn't get to that slide. So now's the time for questions.
So I would thank you for a fantastic presentation, Catherine and Peri. And I must say that it's, of course, music to my ears to hear how small seed funding for your inclusive research could have helped to so much exciting new work, and very much needed. That's for sure. So that was very lovely to hear. And we will now move on to our question and answer time. How it will run, I will read Catherine and Peri the questions that we posted so far. So we have the first question, which is how well do GPs and mental health service work together to ensure the mental health service consumers' preventative healthcare are met?
Sorry, I was trying to stop sharing my screen. I think I've stopped now, haven't I?
You stopped. It's all good.
Yes.
The question was, how well do mental health service and GPs work together to ensure that people with mental illness can access primary health care? Is that right?
Yes, that's absolutely right.
Okay. I guess the short answer is not good, not well enough. Again, at the moment, it's very much pockets. What we are trying to work towards is developing resources and programs that mean that happens across the board. So that we were privileged enough to actually see an example, working with the mental health service that we were working with, of a reasonably good connection between a GP service and that particular mental health service, but it's probably more. It's probably the exception rather than the rule.
And with the work we've done since with the LHDs on the electronic shared care plans, we've seen how the mental health services have been trying to work with GPs, and it's not people's fault. It's that there's a system that needs to be set up to enable shared care. So currently the LHD's information systems and records are behind a big firewall, and there's no easy communication. So communicating with the GP means literally phone calls and faxes. GPs are still probably the only group in the world that are still using faxes. So to communicate with each other, there isn't any, you can't get that through that firewall. So that's what we're working with the LHDs to do, is we're developing templates for electronic shared care, which is held by the GP and shared with the mental health service. They are really keen, the LHDs are really keen to implement this, so it just wouldn't happen without the partnerships with the LHDs. There are many barriers, but we're hoping this will make a difference. So this will be a world first.
Oh, it's so important work. Thank you so much. There is another question from Professor Karen Fisher, who says, thanks. What would these findings mean for people living outside the cities?
Good question.
You want to go, Peri?
Well, definitely they would that relate to people living outside the cities. Except I'm just thinking about other projects that I've done and working with people who have severe mental illness. There's, all these issues, all the barriers and challenges, 10 times worse in the regional areas. So often outside the city, it might even be that there isn't a GP that's easy to access. And when you do access a GP, it's somebody that knows you, your mum, your dad, your uncle. And so there sometimes can be even more judgment or more fear of approaching that particular person. I think some of that may have changed. It may be changing because of the access to telehealth now. I was just speaking with someone last week that has a mental illness, and they live in a regional area, and that they now can access a doctor in a completely different area, and are finding that really useful. So that flexibility again, I guess. But yeah, it's just sort of thinking about access in particular, but also if you do live in a country town and there's one GP and they don't tick all those boxes in terms of being approachable and so on. you're in a bit more trouble there.
And a couple of good news stories related to that. One is that I understand the Commonwealth is going to incentivise GPs using video conferencing, so Zoom meetings like this. I guess they've been fairly reluctant to extend to the video, and which is quite necessary for communication, etc. Sydney LHD also has set up what's called RPA Virtual. So this is, again, it depends where you live, as Peri was saying, but it's an example of what one LHD is doing. So it's making GPs available online. So they've noted with, there's a percentage of their consumers who don't have GPs, and they're hoping that this can be a way of building a connection at least with RPA Virtual. So there's a few things happening, and this is where I say thank you to COVID, because so many people have gotten accustomed to doing this sort of Zoom meeting. A year ago, it just wouldn't have been possible, but we've done various interviews and focus groups and workshops with people with severe mental illness in the last year using Zoom, and we just wouldn't have imagined pre-COVID even trying to do that. So for rural areas, I'm not saying that solves everything. I think, the essential problems that Peri outlined still exist, but there is still some, use of technology that can help.
I think that's an excellent point what you made, Catherine, and it is a very, very encouraging news. I definitely know from my research talking with school principals in rural areas, GPs are sometimes really even not available, and certain parts are trying just to attract any GP. So being able to connect electronically with somebody really is very precious. We have another question here. You mentioned MHS doing preventative health assessments. Do GPs and MHS share assessment data?
At the moment, it's pretty irregular, and as I said, it can be by fax. So that is the beauty of the electronic shared care system that we're setting up. So that it feeds right into the GP software and uploads automatically all of that screening data. And so at the moment in the LHD, the mental health services are doing some of the screening, because it's easier to do the health screening themselves than to send the consumer to a GP and then try to get the results back. So we're really hoping that this software really can reduce the amount of duplication and ensure the right amount of preventive care is provided and the results are shared between the systems.
Such important work what you're doing. You have to keep us updated how it's progressing. And we have here the last question. Is there a possibility of people being assessed by both the GP and MHS not sharing information?
Yeah. Yes. I think I answered that in the last answer.
Yeah.
Okay.
There was definitely examples of that. Because I guess also a lot of the people that we spoke to, just because where we recruit them from, like I said, their physical health was now being addressed. And so, so they sometimes were overserviced in terms of, because there wasn't that sharing of information.
Thank you. Thank you so very much, Catherine and Peri, for great presentation. Of course, always as to be expected, some varying findings, but it's really encouraging always to hear about those pockets of good practice. But as you said, they need to be available for everyone, not just for the few privileged ones. I think for me, a really important point that you made also towards the end of the presentation, where you talked about the importance of consumer inclusive approach. And I think that is something we are seeing in research as well as in services, and hopefully this movement towards focusing on people who are in the heart of what we are trying to resolve will continue and flourish. So thank you so much. With this in mind, I would like to thank everybody for joining the Disability Innovation event. To stay informed on our upcoming events and news, please subscribe by going to our website, www.disabilityinnovation.unsw.edu.au. And if you are a UNSW researcher who is interested or works in the areas related to disability, please do contact us at dyu@unsw.edu.au to tell us about your work and also discuss ways we may be able to help to support or promote it. We are especially interested in research that is, as you have seen in today's presentation, that is inclusive, that is really grounded in co-design and co-production, and that is interdisciplinary. So please don't be shy. Thank you very much, everybody, for attending.